All right. Welcome, everybody. Good morning, good afternoon, good evening. And I welcome you on behalf of the FP 2030 to this cross-regional exchange and learning series. And we're going to be looking at family planning in universal health coverage. Conventional African wisdom tells us that when the horse in front of you falls into a ditch, it immediately begins to warn you of where to avoid. Conversely, when the horse in front of you successfully navigates a path, then it makes it easy for you to navigate. So we're going to be talking about family planning in universal health coverage. We're going to be having experiences from countries that have taken up this intervention to ensure that everybody is able to access health care without any financial distress, but more importantly, that SRHR, particularly family planning, is effectively covered. And so today we have an interesting array of speakers. We're going to go through the start off with the FP 2030 Director for East and Southern Africa Regional Hub, who's going to set us up. And then we move into an interesting panel where we will have experiences and an interaction. So please feel free to put your questions in the chat, and we're going to take as many of it as possible. And also do note that we're recording this webinar, and we hope that that will be acceptable to you. We've put up the hashtags and some of the handles that we hope that you can tag as we go along. So we'll begin to at least continue to put out the learning from this engagement. So I do hope we're going to have a very interesting time together. And now it's my pleasure to invite someone who's had extensive experience as a public health expert, particularly in the field of adolescent family planning, in reproductive health, maternal, newborn, and child health. And she has extensively advised organizations, institutions like USAID, Washington, USAID, Malawi, Bill and Melinda Gates Foundation, including the government of Kenya, on strategy to achieve the range of SRHR interventions. And so at this point, it's my pleasure to invite Dr. Sheila Macharia, the Managing Director, FP 2030 East and Southern Africa region, to speak to us and set us up. Sheila, you've got the floor.
Thank you. Thank you very much, Dr. Ademola. Good morning, good afternoon, and good evening, everyone. It's certainly a pleasure to be here this afternoon with you. At the outset, let me begin by thanking FP 2030 and Knowledge Success and the institutions that are represented here today, which include the Government of Kenya, UNFPA, WACI Health, HIVOS Southern Africa, the Center for Reproductive Health and Education, Zambia, and Uganda Youth Alliance for Family Planning and Adolescent Health. We have the opportunity this afternoon to begin the series that has been described to you, which is a cross-regional exchange and learning series to foster learning on policy, programming, and research on family planning in universal health coverage agenda. This series will be organized across several regions, and these include West Africa, East Africa, Asia, Latin America, and the Caribbean. The objectives for the cross-regional dialogue and the learning series are to foster dialogue, amplify lessons, and deep dive into various thematic discussion topics such as financing, research, policy reforms, CSOs, private sector, and others. We also want to share practical examples and experiences, especially flagship programs, approaches, and policies of country-level work that is dedicated to integrating family planning into UHC strategies. And then we'd like to facilitate peer-to-peer exchange on approaches to UHC policy design, policy implementation, and demand creation, and as part of community engagement. the series is allowing us, as Dr. Ademola said, to focus on an area that is very critical for the populations in Africa. We know that according to WHO, universal health coverage means that all people have access to the full range of quality health services that they need when they need them and where they need them without financial hardship. So the goal of UHC is to support a system-wide transition that moves a country away from out-of-pocket payments towards pooled financing, and therefore ensures that all citizens, regardless of their ability to pay, are able to benefit from the full health package that the country is offering. Many countries have defined different levels of care in their health system, from primary to secondary and even tertiary. And a good number of the essential health prevention and promotion, a good part of the health prevention and promotion services are defined in the primary care package. Despite being considered a very important part of primary health care, unfortunately, family planning is often excluded from the UHC. And even when it is included, you find that in costing the essential benefit package, the contraceptive commodities are left out because in many settings, it is assumed that those will be provided by some external source. For this reason, FP 2030 encourages countries to make a commitment so that the sexual health and reproductive rights of their citizens are not neglected, and that rights-based family planning is an essential component of their national health strategies. Then, to ensure that the financing plan for universal health coverage covers all essential components of family planning. In the complicated field of health financing reform, we need to remind policymakers that family planning should always be prioritized. The family planning community has a powerful voice, especially when we work together through movements like FP 2030. Therefore, we will continue our advocacy efforts to ensure that the integration of family planning into UHC happens, and that we will also create learning opportunities like this one so that best practices are shared across the region. In July this year, we have the opportunity to amplify the country commitments at the Women Deliver Conference that have included family planning and its integration in many of them to sexual reproductive health and rights. Today, we look forward to hearing from different countries about their experiences. And now it gives me a great pleasure to first tell you that the next series will be held on June 29th, 2 to 3:30 p.m. GMT, plus 3 hours. And we look forward to you joining us then. I'd like to now turn over to our moderator, Dr. Ademola, and perhaps say a few things about him. He has assumed office as the UNFPA representative for the South Sudan, and that happened in April 2022. He has worked in different settings as a UNFPA representative in Kenya and in Namibia, and he has also served in Ethiopia. His early career was with UNICEF and with UNFPA in Nigeria. He holds a bachelor's degree in medicine and surgery and a master's degree in business ad from University of Ibadan. So without further ado, over to you, Dr. Ademola. Thank you.
Thank you very much, Sheila, and thank you for setting us up very nicely. Indeed, integration of family planning into universal health coverage is one of those things that remains very critical to achieving the success. However, it's also fraught with challenges. And so today we have a very experienced panel who would share their experiences and how they've been able to navigate some of those challenges and show us some of the landmines that we have to avoid. And so please permit me a few minutes to introduce our panelists, and I will, because of my personal bias, will start with the ladies. So I'm going to start with Amanda Joan, who was a former country coordinator of the International Youth Alliance for Family Planning, which was an organization that was an offshoot, came up that was born out of the 2013 International Conference on Family Planning in Addis Ababa. She's also the co-founder of the Uganda Youth Alliance for Family Planning and Adolescent Health, which is youth for youth, leading the process of advocating for their own health. Then she's worked extensively as well, bringing her skills as a journalist to the table in advocating for family planning, adolescent reproductive and sexual health because of her career as a journalist. She represents the Ugandan youth in the Youth Advisory Group that oversaw the organization of the 2017 Family Planning Summit in London on the 11th of July. And she's a youth member of the Youth Advisory Board for Shiswa's project. And of this year, she's the Uganda Youth Focal Point for FP 2030. And so she's going to be giving us perspectives from that point of view. Let me go to Limpo. Limpo Chinika is the program manager of the Regional Sexual and Reproductive Health and Rights Fund at IVEOS, and she leads the program's 2 projects across East and Southern Africa. That fund is a regional grant-making mechanism that strengthens SRHR interventions in East and Southern Africa. The fund's goal is to have a stronger, more coordinated youth-led civil society engagement that can promote access, and of course, also look at the intersections for HIV and gender inequalities across regional level. She's had several roles within that organization and comes with an extensive experience of over 17 years in program management and communication. So she's well equipped to contribute effectively to initiatives that drive social impact and promote sustainable development. And so we're going to be drawing on her passion, on her experience, to see what we can do differently in the social space to ensure that family planning is properly integrated. I go to Amos. Amos Wale is the Executive Director for Center for Reproductive Health and Education in Zambia. He has over 15 years of experience working in advocacy, health system strengthening, gender transformative approaches across the SRHR spectrum. In my previous life as head of division for health at the African Union Commission, he was a very trusted ally in organizing the civil society space. And he had also previously served as executive director for Youth Vision Zambia. He's a member of the Global Advocacy Council for UNFPA and was one of the key members that developed the Family Planning 2030 and 2030 plan and commitment for Zambia. And so he's one of those people who have served extensively and has been a team member of the Zambian delegation to the CPD and meetings for the last 8 years. And so we're looking forward to this strong CSO perspective, which he will give us. And finally, Dr. Ishaq Bashir, who is the acting head directorate for Family Health, Ministry of Health, Government of Kenya, which is one government that are taking very concrete steps to advance UHC and also navigated the bottlenecks of integrating family planning. Dr. Bashir is a public health physician with a background in ONG. He's somebody with extensive experience of over 23 years in health systems, and he has worked over the years across a range of partners, proudly for me, including the UNFPA in advancing maternal, newborn, child and adolescent health, and was somebody who provided strong leadership to the issues of SRHR policy and the family planning policy. Of course, he successfully navigated a memorandum of understanding signed by the government of Kenya and development partners, which was aimed at ensuring 100% domestic funding for family planning commodities. So today we have a panel of men and women who are quite experienced in this particular subject, and we do hope we can learn from them. Again, let me remind you, please put your questions in the chat. So I'm going to take up Dr. Bashir, who will give me, in 5 minutes, the experience of Kenya in integrating family planning into UHC. What were the entry points for integration? How did this work? What are the key lessons? And what would you think we should do differently for other countries to move this forward? So Dr. Bashir, I know it took a long time because I was there with you in the trenches, but let's see what you can let us learn in 5 minutes. Over to you.
Thank you very much, Chair and Moderator. My former boss from UNFPA was happy to work with you. The time given is very short, all protocols observed. I'm happy to share the Kenyan experience in terms of the terrain for family planning. We did not begin family planning journey today. Our second president motto was actually family planning, Panga Uzazi in Kiswahili. So what have we done in the last 1-2 decades in terms of investing and prioritizing family planning? As a nation, we have developed the necessary and implemented the necessary policies that actually prioritize family planning. In our health policy, overall health policy, the reproductive health policy, and FP policy, which is now about to be concluded. We have it in our national strategies, and this just shows that it is a priority for the country. We have our costed implementation plans, and we have our national family planning commodity security strategy. We also have a strategy for total market approach to bring on other stakeholders, not necessarily just the public sector. Within our research agenda of national reproductive health, we have a chapter on family planning. Strengthening coordination and collaboration among stakeholders, the civil society, our donors, our implementing partners, all of them are in one basket in terms of prioritizing the integration of family planning. So we have a very smooth coordination mechanism in place, where we also have it as part of our medium-term plan for the Vision 2030. We have a budget line for FP, as you already know, Dr. Adimola and Dr. Sheila. This is for sustainable domestic funding financing. And we have, to realize that, we have gone into an MOU with our development partners for domestic financing. And come 2026-27, we have committed as a nation that we will not be asking for donor support for our commodity security. We've established also a robust mechanism for monitoring and evaluation, tracking the progress, identifying the gaps, and also use informed evidence-based decision-making. We have our logistic management information system, which is integrated with commodity security. This gives us an early warning and alert system to improve our efficiency on our supply chain. Introduction of the hormonal IUD. I think in the public sector, I think we're the first country in Africa in terms of, this is a very expensive method, but we have agreed to expand the choice for our clients, and we have it in the public sector now. Devolution was a blessing as a nation, where we have devolved health services, and that adds to the service delivery closer to the people. The counties are able to employ their own human resource. They're able to train, and they're able also to allocate resources from their local budgets for family planning, and quite a number of them have already done that. Development and training curriculum for family planning, both in the training institutions and also online and in-house trainings are available to enhance the capacity of our healthcare providers. And finally, successful rollout of health self-care in family planning. This is where now we remove the care of family planning and service delivery from the hospital or the health system based to the individual. And this has really given us a huge advantage in terms of allowing them to take over their own health into their hands. Community health system in achieving UHC is our focus, and the president has personally taken responsibility. We are about to employ 100,000 community health promoters with pay, no longer volunteers, and with kits and with mobile phones and data system. They are also connected to their what's called the EKIS, electronic community health information system, where we are now moving on heavily to ensure that primary healthcare and UHC is actually felt at the grassroots, at the individual level. Close collaboration with the National Council for Population and Development in conducting targeted advocacy campaigns to raise awareness, dispel misconceptions and myths, and also lobbying for resources at the national level with the National Treasury. Finalizing investment case for family planning and engagement with community leaders, religious leaders, traditional authorities to address sociocultural barriers is also a very strong approach that we have used. Not to forget the FP 2030 commitments initiative that Kenya has, and we have 8 commitments to that effect, which we are on quarterly basis following on each track. Finally, in the UHC package of services, FP is included as one of the KEF service providers. Thank you, Mr. Ademola.
Thank you very much, Dr. Bashir. This was a whole menu of achievements that the government of Kenya has been able to achieve, which you have rolled out. Can I ask a key question? Just like you said, for family planning in Kenya, it's got a long history. And Kenya has been making progress even prior to the priority placed on UHC by former President Kenyatta. At that time that the conversation was going on, when UHC was one of the big 4, so to say, was there a space for family planning at that time, and what were the challenges? Because I do remember there were times when the argument was saying universal health care, and some were saying universal health coverage, and there was a whole mix at that time. How were we able to still keep family planning as a key priority? In brief.
Thank you. Indeed, we have been doing great at the beginning. Then in between, we slipped off. Secondly, during devolution, family planning actually fell between the cracks, where we had transferred all the resources for family planning to the counties, and they were made use of to construct roads and schools. We had to have a very big fight to bring it back. After it was brought back, even within the free maternity services, it was a struggle to put it. But luckily enough, I was on the table, and we had put family planning as one of the service deliveries. All along with UHC, the basket became wider, and family planning was something tiny, was looked at something tiny. We used the approach of demographic dividend and used other advocates outside the health realm to spearhead the issue of including family planning. And we also brought the cost of unintended pregnancy on the table vis-a-vis the cost of using family planning. We're still having a struggle with the private insurances, but we have a business case in place now, which we are working together. Otherwise, they were not even ready to sit on the table. Private insurers are paying up to 2% of family planning services. But luckily enough, the government, the public sector is doing very well. And we want to loop in before we lose the private sector and the NHIF. Thank you.
Thank you very much. I note right there that the impact devolution had on family planning and the need to then find a way to put it back, as well as also ensuring that that argument of demographic dividend that shows the economic benefits was one of those arguments that really helped. Thank you very much. Let me go to Amos. How has it been in Zambia? What are the key lessons, like we've heard from Dr. Bashir, and where were those critical entry points that you were able to leverage? Over to you, Amos.
Doc, and it's a pleasure working with you again on this discussion. So let me begin. I think first and foremost, I will want to congratulate the Zambian community, both the Ministry of Health, the civil society, and the cooperating partners for putting up a business case and investment that we are looking at for family planning. And colleagues, you might be aware that Zambia just actually launched its family planning 2030 commitments last month. So we are very, very lucky that the Ministry of Health was able to sign the commitments and launch them. And I must mention that that itself shows sufficient commitment from both parties, the government and the civil society, including the cooperating partners. So now, when you look at UHC is a very broad term, but Zambia in particular doesn't have a strategy looking at the UHC. We are using the health insurance, which is the public health insurance, as part of the agenda to drive universal health coverage. So what we did as a community we were able first and foremost to convince everyone and different stakeholders to ensure that all the methods of family planning are actually part of the public health insurance that is existing, so that people are able to have resources. In doing so, it means that first and foremost, we are trying to increase domestic resource mobilization. Secondly, we are also trying to ensure that we do not leave anyone behind. Thirdly, I must mention that Zambia launched the National Health Strategic Plan recently. And in that document, we have clearly spelled out that family planning is a priority. And fourthly, Zambia also has launched a new 8th National Development Plan that has prioritized family planning as a way to actually achieve demographic dividend that is currently going on, so that we are able to see and utilize that space that is available for both ensuring that resources being allocated are actually not only coming from the Ministry of Health, but also from other sectors, that including defense, including the Ministry of Finance broadly, and the Ministry of Community Development. So for Zambia, that's the way we have cultured in terms of how family planning is featuring. And then family planning highly is featuring at primary healthcare. We've noticed that that's where mostly it's needed. And to ensure that no one is left behind, family planning is actually being given at primary healthcare. So now, as an advocate, what I want to mention is that I'm happy that we do have some colleagues from government. One of the things that we have seen with all these commitments, we need to ensure that whatever resources that are allocated towards either the procurement or family planning are clearly outlined in terms of what they are going to do. So if, for instance, at sub-national level, you allocate resources for family planning, what are they using that? Are they procuring commodities? Are they using that for outreach? Are they using that for demand creation? That needs to be tracked. Once it's tracked, then you are able to see that we are reaching a particular number of people. We're also reaching a particular number of last mile people who need these services. And then we are also monitoring that there is a wide choice. You know, when we talk about choice, it's not only one method, but we're talking about the variety method, that the mixed method is actually available for people to actually access services. Then we are talking about UHC, because UHC comes with choice, UHC comes with availability of method, UHC also comes with the number of people accessing the service at country level, at community level. So in a nutshell, Doc, this is what Zambia is doing. But us as partners and as advocates, we are trying to ensure that the Ministry of Finance, whoever has allocated resources towards family planning, that resource is actually clearly outlined in terms of what it's doing, either procurement, either outreach services, either demand creation. That way we are able to measure in terms of where and how the resource is being used. Thank you so much. If you have further questions, I will be happy to take them on.
Oh, thank you very much, Amos. I think there are certain things you've brought up, which again aligns with what Dr. Bashir talked about, which is the first thing, as they say in Nigeria, person where not they, not they. So if you are not at the table, your issues are not going to be taken into consideration. He talked about the fact that he was at the table. You talked about the fact that you were at the table as well, making sure those things are there. So clearly, we cannot assume it will happen automatically. We have to be at the table. Second thing was the demographic dividend. We need to begin to look at that economic argument in a very strong way for the demographic transition, which we use to put things forward. But what I find very key is what you mentioned about the fact that when you allocate resources for family planning, it's important to say exactly where, what it's going to do, because I have experience where resources are allocated and then people use it all for outreach, not one commodity is bought.
Exactly, you know, so we need to know exactly where the resource is going.
Exactly. So how has that worked? Because I'm sure there'll be some resistance. And how do you navigate that?
That's the biggest challenge, Doc. So currently, what we have done is that we are working closely with both at sub-national level to see where they are allocating the resources. When you have a central procurement system, it becomes difficult to monitor where the resource is at sub-national level in terms of what they're using it for. But in most cases, they have used that resource for outreach. They have also used that resource for demand creation because the commodities are coming from central level. So now you need to be very strategic in terms of if they are only doing outreach services, and what is it that the message that is going out there in terms of demand creation. That way you'll be able to monitor and track. Also, apart from that, we are encouraging the people at subnational level to use some of that resource for documentation. You know, when they're documenting, apart from the usual family planning services that happened after the demand creation, it's important that they actually indicate the numbers if there's any improvement after the demand creation or there is non-improvement, so that they are able to change their strategies.
Okay, thank you very much. And you brought me to a point where I would invite Lipo. You know, how does civil society play a key role in this? Apart from advocating for the integration, which civil society always has the capacity to do, what about this tracking? Because sometimes if we're unable to fully track, how do we then ensure civil society helps government to integrate, but also track the successes of some of those things they're supposed to do? So over to you.
All right, thank you so much, Doc. And thank you for having me on this platform. I think a lot has been mentioned by Amos with regards how civil society is impactful, and also I think in general, and everyone maybe on this platform can also agree that civil society plays a very instrumental role in ensuring that, you know, family planning, and there's also access to universal health coverage. And so I think in terms of just picking it up from what Amos was also mentioning, was also around accountability and monitoring. I think civil society plays a big role in that, you know, there's the civil society has the mandate, 1, 2, civil society has the manpower, civil society has the resources, both human resource and financial, to actually hold governments accountable. And in that, we're also looking at how then the implementation of UHC strategies are also, you know, embedded into issues around family planning, like you had already spoken as well, and also SRHR services. And also how then they are also being included and also adequately resourced as well. So I think from that standpoint, civil society has a big instrumental role in ensuring that, you know, stakeholders as well as government is accountable for their commitments, as well as advocating for transparency and equity, as well as quality in service provision. Because of course, we're looking at a standpoint where we're not trying to make sure that there are commodities, but we also need to ensure that there's quality commodities, and then also the equity of those commodities. So I think in actual sense, civil society does play a very big role in that. And also with regards, maybe I'll also pick it up and also just speak to also how civil society has a big role in advocacy and influencing policy. I think Amos also did touch on that briefly, and I think civil society also can help governments, can help other civil society organizations and other stakeholders as well, in ensuring that, you know, advocacy, like we're doing on this platform, we're talking around issues to do with family planning and UHC. And so I think civil society has a big role to play in that. Of course, not working in silo, but working collectively, looking at how different partners can come into play and also then be able to contribute effectively, because then, you know, when you level the playing field, then you're also able to see that issues are being brought out, and also making sure that right now we're trying to look at an aspect of sustainability. Then, you know, once civil society leaves and pulls out, how are you also then going to be able to sustain the services that you've actually embedded in that? And then also maybe just looking at it from another standpoint of capacity building. I think civil society plays a big role in that. Also in how civil society can work collectively with government to ensure that more or less, if government is not able to reach certain districts, looking at maybe issues to do with transportation, etc., I think then civil society does play a big role, and also you know, maybe different parties, maybe the public sector as well, in ensuring that we're working collectively with government as well as other stakeholders to ensure that commodities do reach people where they're needed. And also maybe just looking at, in my closing, just maybe looking at how the provision, like I spoke around issues of capacity building, like on service provision, you know, in terms of if there's not enough manpower, if there are issues around the delivery of family planning and sexual reproductive and health rights services, at least then, civil society does play a role working collectively with government. And I think on that standpoint, I'll rest my case and ask if you have anything further to ask.
Thank you very much. So clearly, civil society has a role, and that role sometimes varies from activism to advocacy. And I hear you mention advocacy quite clearly. Some of the experience I've had, particularly when I was head of health for the African Union, civil society comes with their activism, and I tell them, African Union is not where you bring activism, you bring advocacy. What do you think we need to do to be able to help civil society understand that you don't bang the table at the AU? There's certain things you need to do, particularly for family plan and SRHR. How do we do that and navigate that space?
Exactly. And I think you say it so well that, advocacy has different strategies. There are moments when you should have your placards up and, you're marching in the street, but there are other moments when you can actually have a seat at the table and be able to converse properly. So I think it's in ensuring that there's proper networking that is done. It's also making sure that you're able then to map out different stakeholders, different line ministries, and also just different partners in the sector, and be able to have meetings with them. I think sometimes we don't need to wait until we have certain platforms to actually engage, but I think also being proactive to ensure that you're able to knock on those doors and say, can we have a meeting? Can we do this? Can we do that together? And I think that's where civil society actually needs to be. We need to engage more.
So thank you very much. The point you've made, which I want to emphasize, is not waiting for platforms. So you see, people will come to me at the African Union, civil society, and say we want A, B, C, D, E. And I tell them, not me. These were what your member states decided when they came here. I don't have the mandate to change it. The boss has left the station. Make sure your minister comes here to say this, then I will change it. And so it's important for us to know where to intervene, when to intervene, and how to do that. And that's really critical. So we're going to be coming back to you. Let me go to Amanda. Amanda, as somebody who has been leading a lot of the interventions on young people speaking for themselves, particularly in the context where we see in our sub-region and region now that we're rolling back on what we call the rights agenda is being attacked. How do you see young people integrating into this? What has been your experience, and what do you think can be done differently? Over to you, Amanda.
Thank you very much, Dr. Demola, and good afternoon, good morning, good evening from wherever we are joining from. And thank you for the question. I'll go straight into it. Like basically from what the earlier speakers have mentioned, how the young people, it's a bit different in Uganda, in the Ugandan context, ever since we had giving the young people their space or their place on the table. It has been a twist or a change in terms of operation, in terms of policy making. And I can tell this right from the policy making process. Like, for example, during the development of the family planning 2030 commitments, we have 6 objectives as Uganda. And I think we were one of the first countries in Africa to launch our commitments. That was on 3rd November 2021. And we went ahead to engage young people as partners. Young people we've been engaged to that level as equal partners, because there's nothing for us without us, and there's nothing that can be done for us when we're the ones who live in our own reality, so we can tell our own stories and be able to even propose and give solutions that better work for us. So when it comes to the development of the commitments, the policies, it's young people's voices have really been given priority right from the start. And lately, our government has taken into action to engage youth-led organizations. That's when the CSOs come into play. Youth-led organizations taking part in implementation, dissemination of these policies. And when you look at who is taking lead on some matters or some issues. Like, for example, just last week, end of last week, Uganda launched the self-care guidelines, and a young person was the one to present that. And, you know, they are at the center of everything today. And speaking about rights, young people have got a certain level of voice today in Uganda when it comes to choice, to voicing out what they need. And I'll give sorry, I'll give a live example. Just I think last month, but one, the Ministry of Finance came out to say they are going to finance contraceptive access for adolescents to be able to mitigate the population boom that is coming up due to the high levels of teenage pregnancies and all that. So when it comes to basically young people, adolescents, youth taking lead, we are having that space in Uganda, but we still have a long way to go. Given that the rights, when we talk about rights, we're not yet fully there, given many barriers like culture, tradition, religion. We still have a long way to go in terms of mindset change for parents, for caretakers, for even within our ministries. For example, I can tell you that within even the Ministry of Health, there's been opposition for family planning, like against family planning for adolescents, but we managed to find always solutions to go around that. And as the levers of our own realities, or the tellers of our own stories, we managed to try to front our interest, to try to front our solutions, and also give like way with them. We reason with them, and we bring in real life stories, storytelling. And that has given us a mileage in terms of accessibility, creating demand. And I'll go a little bit into policies. Yes, we have come a long way in terms of putting all this implementing policies. We are very good at developing them. Implementation is where we have a fault, but we are working towards that slowly, one step at a time. At least we've managed to get as key stakeholders to see that it is very important to have a comprehensive package in terms of dissemination. So if a partner comes up and says, I want to disseminate the FP commitments, FP 2030 commitments, well, the mandate is you go along with the entire package, including total market approach, including the self-care guidelines and all the other existing policy documents, so that it's like a fully comprehensive package that addresses and feeds into the universal health coverage. So that's probably what I could say for now, but in case you have any questions, I'm happy to answer them. Thank you, Doctor.
Thank you very much, Amanda. And I like the fact that you've emphasized that it is FUBU, for us, by us, or not for us, without us. And that is really key. Let me ask you a key question. You talked about the fact that you sometimes have to reason with them because there's also the cultural restrictions. I would recall at ICPD at 25 Summit in Nairobi, November 2019, your president was reading the country commitments for Uganda. And I would say a lot of us held our breath, but it happened that those commitments were quite progressive, but he added one sentence. He says, young people, you have a right to take decisions about your life, but feel free to consult me as an elder. I'm ready to give you advice. So how do you navigate those cultural biases that may continue to hinder access for young people?
Thank you once again, Doctor. That's a very, very beautiful question. Of late, so there's this perspective that, or this assumption that we all know what meaningful youth engagement means. But of late, we've come to realize that it's just on the top, people do not actually understand what meaningful youth engagement means. So we've taken at least, currently we are running engagements with key stakeholders on totally understanding what meaningful youth engagement is. And I can say this is taking root through the SheSource project that is being implemented even in Zambia, Kenya, and in Uganda with different partners, including Kenya, including CARE, Uganda, Restless Development, and many others, young people. I can see some of them here in the webinar. And we are emphasizing meaningful adult youth partnerships, because we know that where the adults are, where you guys are today, you were once like us, and what you guys went through as youths, as adolescents, might not be the same thing as we are going through today because of the evolution, digital technology, and all that. So we sit on the table together, and we analyze the issues, and we like, okay, so you guys, you religious leaders, you need to understand that things have changed, and this is what we need to do together. We can work together. Of course, we've had some positive responses, working with partners that work with the faith-led or faith-based entities and organizations, and also the cultural entities. So we've had that approach to harmonize our engagements, and also the fact that we have support now, like for example, the National Population Council has really fought hard to really spotlight the demographic dividend and how to harness that in favor of development, and they've put family planning at the center of everything. So family planning is now looked at as a development issue, and to do that, you really have to have the young person or the adolescent at the center, and so everyone has to understand that. But we also do recognize that it takes time. Not everyone has a sharp mind or can really resonate with us immediately. So we recognize that we have to be patient and keep doing what we're doing, reinvent the wheel. If we have opposition here, we come back to the drawing table and say, okay, what did we do wrong? Then we devise other means and still come back. So that's it. Thank you.
Thank you. Let me ask you a final question before I begin to take questions from the floor, which I already have and posed to other panelists. How has social media helped in this case, given that the young people are more agile with social media? Has it been a plus or sometimes that backfired?
I would say it's been a very big plus. Social media is like our power tool as adolescents today. And on the other side, in terms of Uganda, it has been a little bit. So if I'm weighing in terms of percentage for the plus, it will be about 85%. If it's for the negative, will be the 25%. But why? Because we take, whenever we feel like there's something not going on right, like for example, when we had the banning of the sexuality education framework, we took it on social media, and then we had partners come and engage and went to court. We had very many campaigns going on, and eventually we had court rule in our favor that we needed a policy, we needed a framework for comprehensive sexuality education. That has actually brought media in our favor, social media to be precise. Twitter and mostly Twitter, TikTok today, and Twitter, TikTok, and WhatsApp and Telegram of recent. So we still have an issue with Facebook, but many, of course, we do recognize that we're still on a lockdown when it comes to Facebook in Uganda, but still that does not prevent us from advocating and using that as a platform. We do Instagram lives, we do Facebook lives, and we use all those platforms to really put our voice out there. And funny, the best thing of this is that these stakeholders listen and they follow all our discussions online. And when it is too much for them or they are overwhelmed, that's when they come out to really take action. So I must say social media has been our power tool as adolescents and young people.
All right, thank you very much. We'll come back to you from the questions from the floor. Dr. Bashir, there's a question that speaks to the fact that we are now in a digital economy, information age, that digitalization may be able to play a role in accelerating this. What has been the experience of Kenya, or what is the plan for us to optimally leverage digitalization to take us where we want to go?
Thank you very much for that question. Kenya has used the social media and digitalization in the earlier phase of our life in reproductive health. And we had a lot of programs that were towards that. But as a nation, I think there is one of the key commitments of the current president, digitalizing services, including healthcare services. Right now, if I talk about the general services, our passports application, our certificate of good conduct application, we have what's called the portal of the citizen. And everything that you want, you will just apply online and you get it. You don't have to go and queue these days, unless you're going for vetting. So coming to health, we have now a directorate of health digitalization, which shows that we want to bring all our data in one place and have access to it for all research purposes. We've been having data in different places, and some of them were stored out of the country. Right now, we want to bring it back home, and there is a database that is being set up in the health promotion sector, and we have a directorate for digitalizing healthcare. In our level 6 and level 5 hospitals, we have paperless, EMRs. Different counties have different softwares, but we want to make it one. And there is also a fund in ICT, Ministry of ICT, which encourages specifically health proposals for digitalizing healthcare service delivery and recording. There was something else that came into my mind that has just slipped out of my mind in terms of healthcare. Yes, I will get to it, but I think we are going big on it. We are not out of the woods, and as a nation, we have our our reach in terms of mobile phone access is very high, about 80% or 90% of our population. And that actually gives us an access on that. And our youth are, most of them, online, and they are accessing the majority of the information, reproductive health information, on the social media. And that is why, as a ministry, we cannot afford to be allowing others to take over. We give the right information to our youth so that they can make the right decisions. Thank you.
Thank you very much. I'm going to go to you now, Amos, particularly with regards to the fact that you sit at the table and you provide knowledge to government. Have you been able to help government link family planning to other mega trends such as climate change? And what is that looking like? Amos, are you there?
Yes, Doc, very much. So for us, family planning is part of the integration that is happening across different sectors. Right now, we have the Ministry of Green Economy, which is looking at the environment. We are working closely with them as they are developing their strategy to ensure that family planning is part of their strategy when they are working. I must mention that I think we have quite a lot to learn in terms of how best we can integrate climate change issues with family planning. We must be very careful. It's quite political, but at the same time, I think there are a number of things that we can learn from others that have done it. But for us, we are just trying to ensure that we are not misquoted. Sometimes issues of family planning.
Hello, I think we lost Amos there. But then when it comes back, let me go to Limpo. There's the issue that sometimes you find governments being very slow to adopt new methods. And we saw from Dr. Kenya's experience that new methods are key. How does civil society help with motivating and enabling governments to adopt new methods to improve the method mix?
So I think that's an interesting question, Doc. I think sometimes looking at the way civil society operates and the way government operates is obviously different. But in terms of how then we're able to work collectively together and also then be able to influence certain changes, I think it's in the matter of how we we go about the engagements with government, and also, I guess, maybe perhaps understanding the role that government has to play. Of course, there are certain things that just can't be decided on the spot. And so, they have to go through certain processes. And I think it's also just as civil society to understand those processes and be able to be present in those processes, just so that everybody on the table knows exactly what is going on. I think the other aspect as well is to ensure that there's an open communication of, it's not everything that requires meetings, but just a point to be that, if there's any information that is coming out, a quick email, and also just it more or less derives from understanding and also knowing the dynamics of different offices, and also being able to establish relationships, and also that relationship building in each of the sectors that we're working in.
Thank you very much. It's just like Dr. Bashir talked about, the MOU and the movement back then in Kenya involved a lot of partners. How do we work with civil society to let them understand that they are civil society, they are not the political opposition? Because there are times when civil society appears to be antagonistic of the government and then create problems when it comes to advancing SRHR. And that we've seen in so many broad spaces. What do you think we can do differently? Because that's a challenge.
Definitely. I think sometimes it's in our approach, and I keep on talking to the approach because I think it's a big thing for civil society. I think one way is to ensure that we understand our mandates. Like you're saying, we are not, CSOs are not political parties. So I think it's in understanding the mandate of the particular CSO that you're in, and also looking obviously at issues to do with your values and your mission, and also what it is that you're actually there for, to ensure then that you're able to work collectively and well with the governments of the day. And I think one way of ensuring to do that obviously is to make yourselves available to governments at any given point. I think sometimes, governments have, there's so many protocols, etc. And I think it's just a matter of understanding that, and also being able to work with other civil society organizations, because I think the essence should be around learning and evolving, as well as looking at ways of looking at each of our lessons learned, as well as best practices as well within the CSO circles. And I think that's an important thing, to ensure that there are certain collaborations that are being made, and also just linking of synergies. It can be synergies with government and CSOs, or CSOs collectively with government, and also just understanding those dynamics.
All right, thank you very much. And I totally do understand that's key. And so we need to begin to do a lot of the experience sharing. And I've seen questions from participants asking for some of the documents that some of the countries have developed, like the Kenyan strategy, like the costed implementation plan. Someone has asked if that was also done at subnational level. And I can confidently say yes. For example, in Kenya, subnational levels do develop their costed implementation plans. Let me go back again to Amanda. Young people have the capacity for making an issue chic, so to say, sexy. How do you think that young people can be supported to make family planning normal, to normalize family planning? Because I still see young people on the African continent having a challenge walking into a store to ask for condoms when it is not obviously on display. What do we need to do?
Oh yeah, thank you very much, Doctor. That's a very nice, interesting question. How do we normalize family planning? And that actually brings in the other aspect. How do we normalize contraception talk? I'm sorry. Forgive me about that. Sorry, having a bit of a tough cough. Okay, so back to the question. My apologies. So how do we normalize the talk of family planning as young people, as adolescents? We need to recognize the fact that family planning is not all about planning for families. It's a life planning. It's a general body planning. It's about awareness. It's about body autonomy. It's about knowing what you want as an adolescent, as a young person, but also the adult partners that we have. How do we communicate the family planning need or needs that we have to them? It's about that kind of the level of negotiation, the level of understanding that we need to normalize and include in our discussions and our talks. And like you said, a young person walks into a store and orders asks for a condom when it's not there. They need to. That's about awareness generally. Before you walk into a store, do your survey as an adolescent, your research, which facility has the family planning that you need. Because one thing in Uganda, we don't have a commodity mix. So we have like some facilities have a high range of condoms, and then other facilities have more of male condoms, no female condoms. And you find that only pharmacies that can have all the almost all the contraceptives apart from the hormonal ones that are given in facilities. So as adolescents and young people, we need to normalize the talk and to listen to information. There's also another thing when it comes to communication, we listen to something and only pick what we want to know or hear. We don't pick everything that is being communicated. Like, for example, they will say, oh, a condom is 100% safe, or maybe let me use an IUD. They'll say it will protect you from pregnancy, but not STDs. And then the young person will only pick pregnancy and will not, because that's what they want to hear. So it's about having a comprehensive communication in terms of normalizing our discussions with the partners that we live with, our spouses, our adult allies, and as peers with each other, before you listen to the other rumor or the myth that is being spread around that, oh, actually, when you use an IUD, your eggs will get burnt and all that. Do your own research. Find out, is it actually true? Can you ask a trained health service provider about it and get the actual facts before you go out to spread more myths and misconceptions. And we need to move out from family planning. It's about stopping pregnancies. It's about life planning. Look at it that way. It's cool. Family planning is cool because I can know when to have my child, my firstborn, when to get married, how to space my children, but also how to plan and invest in terms of economical growth. That's why it is a development issue. Back to you, Doctor. Thank you.
All right, thank you very much. And I like that. So as I go around to the panelists to give their final parting shots, I will start with you, Amanda. Your elevator pitch, your 1 minute parting message in this experience sharing, but which is one thing you want us to take away? Amanda, are you there?
Sorry, Doctor, say that again, please.
Yes, so we're going around for parting shots from the panelists. What do you want us to take away from the experience from the perspective of young people as it relates to integration of family planning in UHC? A quick
Thank you. Yeah, thank you very much. And I would like to take this opportunity in my parting shots to thank everyone at FP 2030, to thank you, Dr. Demola, to thank Dr. Macharia and the entire team at the FP 2030 ESA Hub for this opportunity. And just to say, someone who asked for documents and maybe resources, please go to the collaborative, the community of practice by knowledge management success. You'll find by country, if you want to know any policy document in Uganda, you'll find them there. You can also check at the FP 2030 global website and look for Uganda. You'll find our commitments there. Now, my parting shot is, let's stop looking at family planning as a barrier or as a problem to us, as a problem for adolescents. No, let's look at it as a development issue. Let's look at it as a component that can help improve our economic status. It can help improve our social being. It can help us as adolescents. And I mean to you, the adult allies, look at it as something that can help we, the young people, have a comprehensive health, well-being, and in so saying, universal health coverage. Because today we're trying to integrate family planning in HIV strategies, family planning, maternal child health, family planning, immunization. Let us look at it that way. Let's look at it as a comprehensive package for everyone regardless, because at 9, a young person, a young girl is sexually active. And today there are many factors that are pushing them into unprotected sex, into, let's listen to them and let's give them the opportunity to give us the solutions they want. Because if you cannot give them money, let them have the choice to make their own decisions. It's their life, it's their body. Thank you, Doctor.
Thank you very much, Amanda, and I hear you properly. It's their life, it's their body. Let me go to Limbo. What is your parting shot, particularly taking into consideration the fact that as civil society organizations, you must sometimes find a way to say things that are very sensitive. And I've said at some point that there might be times when we as development practitioners begin to have a group of words that we would find synonyms for in Africa, because some of those words already evoke the wrong approach. What do you want us to do? What's your parting shot?
Thank you so much, Doc. So my last remarks, more or less, is for CSOs to ensure that we tailor make universal health coverage strategies to specific context of each country. Obviously, we have very different cultural, social, and economic factors that come into play across East and Southern Africa. And also then to ensure that in whatever it is that we do, from comprehensive advocacy and policy, robust policy dialogues, as well as any collaborations that we have between governments and civil society and also other different stakeholders, is to obviously make sure that we work collectively. And I'm also getting into Amanda's terms to ensure that we also involve young people, because we can't do this without them, because they are most affected by family planning and universal health coverage. And then also integrating family planning and SRHR services into UHC strategies. Countries should also ensure that services are accessible, they should be affordable. Like I had said before, there has to be high quality, and also thereby leading to improved health outcomes and sustainable development. And also just for CSOs to work collectively together, to work collaboratively, and also just be sure to work together holistically and not in silo. Thank you.
Thank you very much. And I totally hear you on the fact that we need to work together and not in silos. There has to be that coordinated messaging, because one of the things that I do see a lot of the time is different CSO groups pulling in different directions. And I go to Dr. Bashir for his parting shot. I want him to take into consideration some of the issues that have come on the table. And I see that Amos is back, so I'd also give him the time to give us a parting shot, which is the fact that we always want governments to allocate resources to family planning. We come and we want government to allocate resources. Sometimes in advocating, not just for family planning, but for SRHR, we use certain terminologies that rub government the wrong way, so they run off. I have worked with a senior government official who continues to advocate for people's rights. And the moment I use the word bodily autonomy, she shuts down without even understanding what it meant. And so what would you tell us? How would you help us to be able to work with government, with those in government, particularly how we advocate to ensure that we get the kind of results we want? Over to you.
A very tough question, sir. Yes, the area we are working in, SHRHR, is a very sensitive area. I must share this with you that our last reproductive health policy has a lot of petitions. Even now, every day we respond to petitions from the society, from the religious group. So, and our attempts to get comprehensive sexuality education has been falling on deaf ears for the last 20 years. So what we decided to do was to avoid some terms and see how you can achieve progress in sexual reproductive health without really touching on the raw words and on the raw nerves. And therefore, right now as a nation, you know very well that we have a very huge adolescent population. Our under 35 is almost 75%. That's quite a young population. And we're still not able to accept giving FP commodities, contraceptives to our youths. We have now put in a barrier of saying parental consent in terms of for under 17 to access. And of course, you're not living in a vacuum. We are living in a society with values and religion. And sometimes those voices are heard more than the technocrats who are in the health sector. So I think the issue of bringing them on board, looking at these issues, we're doing the SRH, I don't know, for sexual reproductive health policy now for youths and adolescents. And we have brought in the religious group. The church is sitting there. The Muslim, what do you call, the Supreme Council of Kenya is there. The parents are there. Everybody's there, and we're developing it together. And we've not had really bad experiences. When everything is on the table and it is explicit, everybody puts his point forward, and they get out of their cocoons. One time I brought abortionists and anti-abortionists together to do a document, and we managed to do it. Everybody has his way, but I think running with an agenda solo is not going to help. Just bring them on the table, and they will accept 80–90% of what is sensitive now because of misinformation from the media. So in my parting shot, I think we have an opportunity of using technology to really give information to our youths and give them the right information. We have to address issues of equity. Within Kenya, we have a good CPR of maybe 58–59% now. And our target for 2030 is 64%, which is very good. But within this country, we have places which are 2% and a place which are 70%. So this disparity in the principle of leaving no one behind is something we need to address. Addressing the social determinants of health, education of the mother and the female girl, the girl child, monitoring of these commitments, which we do at global level. For accountability. It's very, very important. With those few remarks, I say thank you.
Thank you very much, Dr. Bashir. And I totally agree with you on the approach of putting the things on the table and focusing on the results we want. I will tell you straight away, and I say this without sense of responsibility, I totally agree that we must provide comprehensive sexuality education to young people, particularly within the school system. One of the things I keep saying is that we do not have to call it comprehensive sexuality education. That has been the greatest challenge we are having, putting that name through the door. I don't know how many of us on this call are Africans, but I will challenge each of you to translate comprehensive sexuality education into your mother tongue and see how it comes back to you and how you want to take it forward. Because I hear in English, but I also process in my mother tongue. So I'm going to go now to Amos for the final parting shots. And there are two things I want you to consider as you give us that parting shot. One, how would you, with civil society, help with regard to equity and avoid what we always see as a tyranny of averages when we are doing so well as a national average, but then doing so badly within certain groups? And also how we then advocate those difficult conversations we have to get us to where we want to go. Over to you.
Thanks, Doc. And let me begin first with the most difficult one, which is having the difficult conversations. I think Doc was very much right. We need to bring everyone together. We can't continue avoiding people. People from the religious circle or from whichever circle they're coming from are key, and they need to understand that we are up to good, not that we're up to no good. We are trying to prevent a number of issues, and we are trying to ensure that our young people are kept in schools and they are not falling pregnant. These are the same members from the church and from the Muslim community, from the mosque. So we need to protect them and ensure that we are able to have honest conversation. Secondly, I must also mention that in Zambia, we have changed the name. It's no longer called Comprehensive Sexuality Education. I think because of the same reasons you have given. We have kept the content, we have changed the name. So, for me, that is a big win. We haven't changed anything. We haven't lost anything.
Where the only thing is that we've put it to the name that everyone is happy with, and we are going ahead with the content in the menu. And then thirdly, I must also mention is that this is not a fight. If we are going to show like we are fighting with the opposition, we are not doing any justice to ourselves. Let us have a dialogue. Once we have dialogue, it's important that they will understand. Thirdly, let's also not have high expectations of asking the religious leaders or religious people to do our work. Let's tell them to respect our work, and then we also respect their work. And we tell them, let's not talk about against each other. Let's ensure that whatever we discuss, there's a lot of factual information. That way, we'll be able to see progress. And for me, I think that is the way it has been working, and it's been very, very progressive. Now, coming to the issues of equality, I think first and foremost, let me begin with the platform. We need to ensure that the people who are on this platform, we continuously support advocacy. I think advocacy is one of the key elements that is going to help us ensure that we actually monitor, we see the results we want. So if we don't support advocacy, I don't think we'll see much of it. As much as service provision is important, it is key that we support advocacy. Secondly, we need to ensure that whatever we do, there's accountability. Equity will not come on its own. We need to ensure that accountability is part of what we want to see. Once there's accountability, then there will be equal distribution of resources, there will be equal distribution of commodities, there will be equal access actually for these commodities wherever they are at last mile. And that's something that we are looking at. In that way, we'll be able to see that people have access to the commodities and we are able to see results from that angle. Last but not least, we need to ensure that there's transparency. Once there's transparency, then the other top parts actually fall in place, accountability. Then we know that what the government is doing, what us as civil society are doing, and what the cooperating partners are doing are all actually being equal, and we are showing that this is where we are spending our resources, or this is where we are putting our resources. I end here, Doc, and thank you so much.
Thank you very much, Amos, and that's a brilliant place for us to end the panel. Let me thank every single panelist for this rich discussion, because this has been helpful, and I'm sure that this learning is being curated. And so we're looking at going forward from the panel is to have a discussion. We're going to have a discussion, Fitsum Alumayo, who is the African Union Liaison Officer for WACI Health. Fitsum is someone who has a rich experience in the field of research, and he has led numerous researches around education, livelihood, health, agriculture, nutrition, and a range of them. He continues to interface with the African Union Special Technical Committees that have a role to play with regards to policy dialogue and decision-making as relates to health, RMNCH, and also the CSO partnerships necessary to move this agenda forward. So in my previous life at the African Union, Fitsum would have had to work with me, so I can assure you that his job is not exactly very easy. So he'll be telling us how governments in Eastern and Southern Africa can effectively contribute to a strong outcome during the second high-level meeting of UHC that provides opportunities for advancing family planning and SRHR, and some of the challenges that are confronting the implementation of some of these political declarations, especially the one adopted in 2019. Fitsum, over to you.
Thank you very much, Mr. Moderator, for the generous introductions. I believe I am audible. I might have some internet challenges, but kindly bear with me. So thank you very much. Introductions, as mentioned, my name is Fitsum from WACI Health. Before just diving into the actual presentation, I would just like to bring to your attention some of the important timelines leading to the actual high-level meeting of UHC, which WACI Health is very much involved, and also coordinating civil societies across the three high-level meetings, starting from also the multi-stakeholder hearings that happened in May 8 and 9 in New York. So the high-level meeting on universal health coverage will happen on the 21st of September, and we expect a more revised political declaration, which is a follow-up of the 2019 declaration. The zero draft was out on the 24th of May, and so the final written submission for the zero political draft will be the 3rd of June. the coming Friday. So we'll also have the high-level meeting on pandemic prevention and preparedness and response on the 20th, and also the high-level meeting on TB on the 22nd of September. So just for also as additional information, the HLM on UHC will be co-facilitated by Thailand and also Guyana. So our participation during the high-level meeting during 8 and 9 of September it was very important, whereby civil societies had a very coordinated approach, and also we had also the privilege to speak in moderated panels. We had the privilege also to attend so many side events, whereby we had also the opportunity to present our key asks and also consolidated asks as well. We also had a very high-level lunch event member states on the 9th of May, whereby we were privileged to have a good member state participation in this lunch, and we also participated and presented our UHC action area asks, which I will touch upon. Also with our TB colleagues, and also we very much work on TB as well. We had the opportunity to visit 49 permanent missions in New York. From there, the African Union mission, also other African Union permanent missions were also part of our visits, and as much as presenting on, it was also linking into the UHC and also PPR asks that we did present. So what is the action agenda of the UHC 2030? So one thing I forgot to mention in my introduction is we host the communication and advocacy function of UHC 30. So that's why you see UHC 2030 on my presentation. So we have 8 action areas. Action area 1 is to champion political leadership for universal health coverage. 2 will be to leave no one behind. 3, to adopt enabling laws and regulations. 4, to strengthen the health and care workforce for quality healthcare, and 5, to invest more and to invest better. 6, to move together towards universal health coverage. 7, to guarantee gender equality in health, and 8, to connect universal health coverage and health security. So what does this mean at national level? At national level, as civil society and communities, we need to make our voices heard, and we need to also influence our governments, and also to have a more coordinated approach towards health coverage, to advocate and also to call for government to participate in the high-level meetings in September. And also here, we would like also to bring to your attention, it's very important to have CSOs or community representatives in the delegations. The other one, we need to advocate for governments to make ambitious commitments towards universal health coverage, as we only have less than 7 years to attain most of the commitments, and also to hold governments accountable to what they have committed to. So we also need to be UHC champions in our respective countries to look into the above mentioned action areas, to disseminate them widely in our networks, also to influence some of our messagings based on these areas. So UHC action agenda from the UHC movement is that it launched in the 27th of March 2020. It's available in French and English. Available on the UHC 2030 website. We have a short version available for printing in 6 UN languages. We also have a very comprehensive social media toolkits. So this is what the timeline looks like in terms of reaching to the actual high-level meeting on UHC on 21st of September. So we are almost now in June, and we have the first political draft out, and inputs are being also made by our respective governments, and we're also pushing a mission and also at national level to reflect some of the key civil society asks looking into the zero political draft. So these are some of our materials that you can find on our website. So what should governments do in relation, especially looking into Eastern and Southern Africa governments, but also focusing more on family planning and also looking into the gender gap. So we call on governments to fully deliver on all commitments to gender equality and equity, the human rights of women and girls, and sexual and reproductive health and rights, and also to make the 2019 UHC political declaration, or to be part of it. The other one is to design, implement, and finance gender transformative UHC that reaches the furthest behind, and recognizing that this will be effective for all people, to engage women, girls, and gender diverse in their diversity, and also to meaningfully engage in UHC processes, starting from the design, budgeting, implementation, monitoring, and evaluation, to effectively design, build, and strengthen public health systems to be resilient to health, economic, climate, and other crises, and also importantly to expand on commitments to gender equality and human rights of women, girls, and people of all gender in the context of UHC, and in terms of enabling environment and determinants of health, and also look into the health workforce, finance and investment, leadership, and also decision-making, and most of all, to have a gender-responsive health service. Finally, we also to ensure that accountability and transparency in all actions are kept, also to bolster collective action towards the attainment of the UHC 2030 targets, to analyze this based on disaggregated data. I hope I have time. Moderator, I would like to give it back to you. Thank you.
Thank you very much, Fitsum. This is quite helpful. So if I may, as we round up finally today, can I ask you two simple questions? Who are the people who will be developing the draft political commitment? And so what can our stakeholders, our community begin to do to engage them at the national level? Is it going to be the diplomats? Is it going to be from Ministry of Health? Is it going to be CSO? Because sometimes we're talking to the wrong person. The second question will then take up from there. Who will be those who will adopt it? And what do we need to do between now and September to make sure they understand what they are adopting? Because you and I know people come to those platforms to adopt documents they have little knowledge about. Holding them accountable for implementation then will be a joke. Thank you.
Thank you very much, Mr. Moderator. So the first question would be, this process for UHC is led by Thailand and Guyana. So those are very important countries we need also to keep in mind. So wherever we have those missions in our respective countries, we need also to link up with those countries or those missions in our respective countries, the diplomatic missions, their diplomatic attaches, or any equivalent diplomatic proactive countries. This will be also very important, whereby we need also to create the link, if the link is not already created by within the Ministry of Health, and also those who are the focal points who are leading the negotiations from country level. The other one is also the mission visits also we did in New York were quite helpful in terms of to learn who will be the focal lead negotiators in countries. So for example, I am based in Ethiopia, and also that really helped me to come back to the Ministry of Health and identify those colleagues who are leading these political negotiations. The other important thing here also is that there is a group called African Group, which negotiates on behalf of the continent. And also within the African Group, there is also a division of responsibilities. So when we look at the universal health coverage responsibility, it's Egypt, Algeria, and Sierra Leone who are actually leading these negotiations on behalf of the continent. So it's also quite important to make linkages to those countries. The other one is also to be very vigilant, go to the Ministry of Health, and also try to identify who are the lead negotiators nationally, because we only have 2 months of negotiation on the actual political declaration. May I ask you to rephrase the second question, please?
You've actually more or less answered the second question as to those who will eventually take a decision to adopt it.
Yeah, so so from experience and from what we got so far, it's going to be done on 2 levels. One, there is the mission in New York, which is actually leading in some of these negotiations, and we were also back and forth, especially since the TB Zero political draft was out. We had also an idea on how we can influence UHC, and also PPPR coming in few weeks. So it's going to be coupled with lead negotiations at New York, but those will provide the written inputs. However, the real negotiations will be led from governments and from our respective governments, especially focal points from Ministry of Health, who will be taking those decisions. The actual decision will be made at country level.
Thank you very much, Fitsum. At this point, I really want to sincerely thank every single person who's participated in this experience sharing, but especially the speakers. Dr. Bashir, thank you very much. Limpo, thank you very much, Amanda, Amos, and of course, Fitsum. What we've been able to take away from this conversation is the fact that yes, we still may be confronted with significant challenges with regards to integration of family planning in UHC or within the health service delivery system, no matter what we've called it. But one thing is clear, it is doable. National governments are able to take up the responsibility of financing family planning 100% with a stepwise increase. We've learned that it's important for us to be at the table with the information, with the knowledge, and have a firm understanding of the context in which we are discussing and we're negotiating. We must build our capacity as advocates, and where we are civil society, we are not an opposition to government, but we are partners who need to coordinate with our messaging and with our approach. And that's very key. We must ensure that policies that we push for its adoption, we also work with government for monitoring and ensure that they are stuck to. Obviously, we must give a space for the voice of young people, ensuring that there is nothing for the young people without the young people. Given the demographics of our population on the continent, it's important for us to ensure that young people not only have a voice, but they have access to services in a way that meets their needs. We must be able to leverage not only information technology, but digitalization to ensure that at subnational level, we have an overview of what happens up until the last mile. We must avoid the tyranny of averages and ensure that everybody is able to access family planning in a manner that meets their needs. We have indeed had a rich learning today, and I do hope that this experience will be able to curate the knowledge as we move on to the next knowledge, to the next experience sharing and knowledge sharing session, which will happen for Northwest and Central Africa on the 29th of June at 2 p.m. to 3:30 p.m. GMT +3. And I do hope that we are able to join that. I sincerely thank Knowledge Success and FP 2030 for putting this together and providing this opportunity for us to cross-fertilize ideas. So on behalf of everybody who's put this together, thank you for the opportunity for me to moderate this very interesting conversation. And I look forward to being part of the next learning series. So thank you, everybody. Asante sana, shukran jazilan.
Thank you very much for able moderation.